This talk will be a little less discouraging than our last. But we're always worried about rating things. And now I've had a scientific interest and actually a real interest in clinically in patient-reported outcome measures. I think they're worthwhile. But the worry that we always have is they're going to use these patient-reported outcome measures somehow against us. So I tied this talk together in ratings and patient-reported outcomes to talk about how they use these patient-reported outcomes when they're rating us. And I'll give you, so in case anybody's tired and needs to blow out or I'm boring anybody, I'm going to tell you everything that my talk's going to tell you here in the first slide. The government would like to rate us, government and payers would like to rate us using patient-reported outcomes. They are having a very hard time doing this, and I think they are never likely to be successful. And there's a lot of evidence for that I will go through. They are more likely, I think, to use them for judging appropriateness, and I'll go through that data. But in the end, right now, if you look at the rating things, and I looked around, different things that we're rated by, we're still rated more than anything by patient word of mouth, the old way that all of us old guys started in practice, and all you young guys, believe it or not, are facing the same thing. So that's my talk in a nutshell. If you want to take off, you can, and hit the craps table. So actually, government wants to use patient-reported outcome measures to monitor quality and to assess the quality of providers. And that didn't come out of some nefarious thing like I want to destroy doctors or anything. It came out of, in the Affordable Care Act, there was a national quality strategy, and it was all part of the move that was driven by Harvard Business School and everywhere else, that we moved from quantity to value in our payment models. And you got to be able to judge value somehow, and they said, okay, well, scientifically, patient-reported outcomes are valid. They measure what we want them to measure. We should use those to monitor quality. And they built it into the payment systems. CMS built it into the payment systems with the plan to have really at least 50% of the payments by 2020 based on quality measures, and a large part of that quality measure through MIPS and MACRA were patient-reported outcome measures. And they build into the payment system first rewards for people who were collecting these through MIPS and MACRA and the bundled payments. And ultimately, by 2020, penalties were kicking in, and they do in the bundled payment models. But neither the penalties nor the rewards were really great enough that there's become any widespread uptake of people routinely collecting measures in clinical practice. Oops, I went backwards. There we go. So, what are the barriers to why haven't, despite these being very good measures of outcome, why haven't they been routinely taken up? And there are really four things as defined by Boyce in a large review of papers, Boyce and Brown in a large review of papers. And the thing that really prevents physicians from using these are, first of all, there are practical considerations. It did cost money and really change your clinic flow to collect these things. And methodologically, people weren't sure if they were measuring the right thing. And largely with EMR's collections, they're much easier to collect, so and there's enough data out there that they work well and they can work well for your specialties. So those two aren't really. Bigger barriers are attitudinal and impact. So how will they be used? Of course, we're always paranoid as physicians, so how will they be used against us? And maybe more important from our own internal doctor point of view is, are they really worth collecting these things? What are we going to do with them once we collect them? And the attitudinal, there's good reason to believe that's true. Even from this is a paper from really the people who the main gurus in patient-reported outcomes. These are biometricians who believe that you can measure anything using these things and truly believe in the usefulness of patient-reported outcome measures. This is a paper from them in our JBJS, and they use really stupid language. There's a lucidity of concept and the ambiguity of implementation. Basically what they say, hey, it's a good idea, but right now we're using and applying them so haphazardly that it's going to destroy everything. So there's no point in trying to do anything with these things because we don't know what they mean. So that's essentially what they're saying in that fancy language. Now there is a fair amount of language over 30 or literature over 30 years that have looked at these things, and because they've been around for a long time, maybe not in routine clinical practice, but they've been useful in people trying to figure out how to use them. And consistently, they show across all the studies that they are useful in helping patient communication. The doctors can uncover things that are not necessarily the patient doesn't want to talk about, those things. They're useful for communicating with the patient. But none of the studies have found any influence on outcome, and there's been no value demonstrated in distinguishing between providers. Now, the biggest literature to look for and the biggest experiment to look at is actually in the UK. So in 2009, the UK mandated that for all hernia operations, hip replacements, knee replacement, varicose vein procedures, that patient-reported outcome measures were collected preoperatively and at several time points post-operatively. And the plan was exactly what the plan sort of was from the National Quality Committee was, if you give patients this data, they'll choose the good doctors by their feet. They'll look at this data and they'll go and they'll get the right piece. It'll allow governments to evaluate, health systems and who's providing good care and not providing good care. In England, where the trusts are locally based, so the tax dollars from the local area are paying for the hospital. They'll be able to judge the quality of their hospital, and they could use it for recredentialing of doctors. And unlike in the United States, where they just said, you should collect these and we'll give you a pittance for collecting them, they actually the health service took on the responsibility of collecting all this data. They contacted the patients. The patients would do it when they came to the office pre-op. Post-op, the government, the National Health Service took care of all the collections. And they did a very good job at stratifying using a lot of statistical things. It was a really good job. They did it. I was very impressed when I looked over this stuff. And then they provided a website that you can go to at any particular hospital trust or hospital and say, okay, I want to see how this hospital is doing for the in total hip or total knee, and you can see here the blue dot is the hospital, and the blue dot is the national data, and the gray bars are that hospital's data. So they're right on the average of the hospital data. It turns out, though, it was all pretty useless because everybody was around the average. Turns out that across the spectrum in the UK, just like I would imagine here, and something that's been well trained in our orthopedic community, everybody does a pretty good job. And when it comes down to it, you do a pretty good job, the outcomes are about the same. And there's not a big difference. So before you could see any difference in providers, you had to get out past the third standard deviations. You had to get out to 99.5, the 99.5th percentile, before you could call a surgeon an outlier. So they weren't very useful. You can't judge, if everybody's the same, then you can't judge any difference using these measures. So they followed this up 5 years later as several studies to see if there was any usefulness in what this big experiment they had done and connected. And what they found was there was very little impact, and it was data uninterpretable. As I showed, most everybody was in the middle, and when there was an outlier, 35% of the time it was a different person every year. So people bounced in and out of that very small thing, but nobody was really in it persistently. And there was no change in the overall variation over time, and you would expect that if somehow this data was providing improvement in performance, you would expect that was better. They also tried to look at, okay, well, we'll pay, we'll dock people for being an outlier. And so they had to pay for performance if you were outside that 3 standard deviations from the mean. So they affected 0.1% of the orthopedic surgeons in the UK, so not very useful there. And now the interesting thing, the plan was we'll have the patients vote with their feet. So they wanted to see what the patients who were getting the hip arthroplasties, what they thought about this sort of thing. Well, turns out nobody even knew the website existed. And then the ones that did know about it had no idea how to use it, and no one ever looked at it, and they did survey, what did they do, and it came down to what their primary care, what their family, what the things, and location. Location was important. Now, it's not so different. Since I was looking at rating scales, there are rating scales in the United States that use data. You can go to CMS Compare, or to CMS Compare, Hospital Compare website. You can compare hospitals and physician. Not many people know it. You can go to a terrible website by ProPublica that has data, supposedly data. It's terrible data, but nobody knows about these things. You go to the CMS website, and I did this, and I pulled down, 3 of our doctors, trauma surgeons, my colleagues, and essentially there's no data on there about anything. So everybody goes to rating sites like Health Grades, Vitals, or standard Yelp, like everybody else gets rated in the United States. It's by your patient word of mouth and reputation. People don't really, on these sites that even propose to use data, people don't know about them and they don't go to them. And one more thing against using these outcome measures because they are, I was part of what worked with the NIH and PROMIS to create these measures. They are very good. They measure what they're supposed to measure. But the outcome, if I'm looking at somebody's physical function after an operation, there's some component of that has to do with the technical aspect of my surgery and my dealing with the patient and their post-operative care. There's large parts that aren't anything that I'm doing. It's their rehab, their house that they live in, their family support system. It's all stuff that really may affect their outcome, but isn't something that you can judge the physician by. And there are studies that show really only 10% of what the patient's recovery can actually be attributed to the surgeon. So ultimately, I don't think anybody has to worry that they'll use these measures to somehow rate us. I don't think that's realistic. And in fact, one of the really big people in outcome measurement, a guy named David Sella from Chicago, who is on the National Quality Forum, and they keep trying, well, how do we do this? How do we do it? And I had a big conversation with him at a meeting, and we were discussing this, and I pointed out a bunch of things to him, and he said, yeah, everybody wants us to figure this out, but there's really no way to figure it out. And that was said in that big paper now, that doesn't mean, I think, that they're not useful or that payers and the government might not use them for something. And the data that emerges is a little different. So definitely can improve communication, and I find that in using them in my own practice. And undiscovered comorbidities, especially I find in my own practice, uncovering depression is a really important thing, because there's a lot of people that I never would have imagined were depressed until I see their scores, and that then changes my whole evaluation of what I'm doing in their thing. As we get data and we know what to expect in the thong, we can tell people. And right now, it's helpful for me when somebody comes in and says, I'm complaining of pain, and I can show them the graph that their pain has gotten better over 3 visits, and I can say, look, you're at the average of the general population now. They're like, anyway, but those things I think are valuable. But what the payers and regulators may look at them for are appropriateness, because there is emerging data that says, maybe that we can pick up some things that these measures are telling us that we maybe shouldn't operate on these people. And this was a really classic. The older people here, older orthopedic surgeons will remember in training, we were told, never operate on a bunion for cosmesis. That was a standard thing we learned, like ever, because you'll be sued, because they're never happy. The patients are never happy. And here's a study that was done at the University of Rochester and some other places, but published in Foot and Ankle. And it looks at foot surgery, and it shows that if somebody had a preoperative physical function score below 29%, below a 29th percentile, they were going to get better and be happy. And the people that were above that, pretty unpredictable. And then if you put pain in there, if people, this was the physical function part, but if you operated on somebody who had a physical function score of 42, so that's one standard deviation below the population mean, 94% of them were not happy with the result. And if you had a pain T-score, so 50 is the norm for the general population, so if your T-score was less than 55, higher number, more pain. So if you were less than 55, you had a 95% chance of not having any improvement in your outcome with the foot surgery. So that was somewhat indicative. And if you look, everybody's familiar with this map. This is this is a Dartmouth map for spine surgery, variation in rates in spine surgery across the country. So the red areas are the highest rates of spine surgery, and the light green areas are the lowest rates, and that's the distribution across the country. So the rates of spine surgery across the country are very variable. And you say, well, should they really be that variable? If you drive through Wichita, Texas, you could end up with a spine operation. Anyway. So they may begin to look, and particularly with depression, because we know there's a lot of data that in the spine literature that you all know better than I that shows that, if someone's depressed, it's hard to get them better from their spine point of view. And we always sort of thought of that not just in spine, but all our specialties. We said, well, they're in pain, of course they're depressed. And it's interesting, this is data from our Spine Center of Excellence. This is from a collection of outcome measures in our Spine Center of Excellence. And we thought this was very interesting because 33% of our patients had severe pain. Only 11% of those were depressed or severely depressed. 36 moderately depressed, but 11%, maybe that 11%, we ought to address their depression before we start to worry about addressing their pain, or at least do them concomitantly. And the same thing with the moderate pain, we still had people that were severely depressed. So it's definitely something that has made us start at the Center of Excellence to think, well, this may be important data that we should consider in how we start to do that. Important enough that now at the Spine Center and the Orthopedic Center in Los Angeles, we've put a psychologist, social worker in the orthopedic spine center, orthopedic center, who, when we get these severe depression scores, we can bop them over immediately to this person to be helpful in that regard. So how are they rating them? And I found this paper very interesting. So who are the rating sites? What do they do, and how are we being rated? And this was a recent paper in Spine you may be familiar with. They took a bunch of spine patients, almost 800, that they asked to fill out a surgery. What was the most important thing in how you picked your spine surgeon, right? And it turns out number one was board certified. Number two was they were in your insurance network. Now, they didn't ask that whether location mattered, but we have from our data in our 1-800 data for calling Cedars, location, I'm sure, would be number three. And those are high up there. And then it comes down to, like, is the doctor a good communicator? Do they friendly? Do they know what they're doing? So that's the same as it's been for the last 60 years. When you don't get down to where the reviews, the online reviews are important until they consider that sixth. And a bad review is just as good as a good review, and either way. They don't pay much attention to them, you know. They don't seem to trust them online that much, and they never trust the internet stuff. Ultimately, the consumers equate quality with reputation. So no matter how you look at it, your reputation is the thing. Health grades, it's just what the patient thinks of you. They're not using any data to do that. So in the end, regulators are interested in using patient-reported outcomes to evaluate us, but it's not, I really don't think they're likely to be able to do this. But they may use it, although a better measure, wouldn't you rather just give them your patient-reported outcome measures than fill out the hundreds of pages of justification for a surgery? I'd certainly rather had that. And so they may be used to judge for appropriate, but in the end, you're building your practices by the same things they've always been: availability, affability, and ability. So